Thank you for including me in the program. It's unusual to speak in the Gulf and be one of 3 Canadians and in the majority nation speaking, so a privilege. So the title is fairly ambitious, cardiomyopathy and genetics, and what I'm going to do is focus particularly on dilated cardiomyopathy. Clearly in the modern era there's great enthusiasm for genetics, but the reality is that, and this European classification emphasizes this, we start off as clinicians and it's not a myosin binding protein C mutation that walks through the doors and sitting in front of you in the clinic. It's actually a patient with a symptom, a faint, a funny electrocardiogram, or a family member who's had some cardiac event at a young age. So we start off with a phenotype, and the emphasis of my talk, if there is a message, it's the broader phenotype of dilated cardiomyopathy. And clearly we try and go all the way, the family history, find the gene, characterize it, understand the molecular basis. We're early on. I'm sure if we look back in 30 years, we'll realize we were in our infancy here in relation to this. In terms of a phenotype, as cardiologists, when someone mentions dilated cardiomyopathy, we think of someone with heart failure, breathlessness, exercise limitation, fatigue, and with this kind of a fairly horrible looking echo. The phenotype is broader, however, and yes, you can talk about sensory neural deafness and retinitis pigmentosa and skeletal muscle involvement, and these are fine print, but the primary arrhythmias, conduction disease, and primary atrial arrhythmias and ventricular arrhythmias as part of the phenotype are very important, and that is what the message is, as you will see as I go on. Our understanding of dilated cardiomyopathy depends a little bit on when you went to medical school, and it's always interesting to ask patients what the problem is, and you can tell when their doctor went to medical school. It's either a virus, an autoimmune condition, and more recently it's even genetic. And of course these are not competitive scenarios of pathogenesis, they all link. So there's triggers, virus, alcohol, pregnancy, and a lot of people get pregnant and a lot of people drink, and we all get viruses. What determines getting to this stage? The pathogenesis is inflammation, and it's in a subset. There is evidence of autoimmunity with autoantibodies, cytokine inappropriate class 2 expression in tissue. But the bottom line is here, is the genetics. And virologists have gotten money for 40 or 50 years studying various strains of mice, upregulating and downregulating the immunity, changing the amount of virus. The thing that matters most is what strain of mice you're using, not how much or which virus or what you do to the immune system. So this is clearly a key in understanding this. The other aspect that's still, even though the early papers from the 90s, Virginia Michaels, Mayo, and Phil Keeling from us, recognize the familial basis, this is still sort of begrudgingly accepted by us as a cardiological community. It doesn't focus. And a statistic I like, Dan Jacoby at Yale has done a study where he's looked at the US transplant registry, and I think it's 5% who've had a heart transplant for dilated cardiomyopathy under the age of 50 have familial disease. And they've gone into their Yale transplant population, which is about 350 over a long period of time, and just done a questionnaire and then followed up with a telephone conversation. It's 35% have evidence of familial disease. So, and clearly if you're dealing with a transplant patient, the last thing you want to tell them is, and the kids may be at risk as well. It's a difficult clinical scenario, but this hasn't gone into our consciousness in terms of managing heart failure adequately. And this is data from our center. This is 767 asymptomatic first-degree relatives. So we've removed from this population the 25% that when we evaluated the proband, parents, and siblings, we found evidence on ECG echo of dilated cardiomyopathy. We've removed that 25%, or the guy who tells me my cousin had, or my brother had a transplant. They're removed. These are the asymptomatic first-degree relatives. And we've just done history physical ECG echo, and 10% had a depressed fractional shortening, 14% had left ventricular enlargement. That's more than 115% predicted of Walter Henry, which is border zone. And then 5% had both of these. So you could say 25% plus 10 plus 14 plus 50, that's over 50%. And you can criticize this data. These are all based on what is normal. We did a number of things, but we looked at metabolic exercise. We biopsied 30 of the asymptomatic family members. They had inappropriate class 2 expression in tissue. We looked at autoantibodies. 20% of the probands have an organ-specific autoantibody. 35% of the first-degree relatives published in Circulation. There's clear evidence of familial disease, but the proof of the pudding is what happens to these people. What happens to them longer term? So this is months, and the individuals with left ventricular enlargement or depressed fractional shortening go on to develop either dilated cardiomyopathy, require a transplant, or die suddenly. So what's relevant to that? Well, first of all, there's familial disease, so that should be factored in when you see a patient. The other is there's the potential to identify genes. And it's the genetic potential that has led to the recognition and whatever classification of families has happened. You could say, hypertrophic is presented a disease of the sarcomere, and right ventricular is a disease of the desmosome. DCM is presented as a disease of the cytoskeleton. And what does that mean? Well, here's a cell membrane, and some of the genes that cause dilated cardiomyopathy are actually linker genes to the extracellular matrix. So this is the dystrophin-associated complex. So that's a structural element. Other genes are actually related to structural elements of the sarcomere. So the Z line is a structural element, so there's Z line mutations. There's others, MLP and others within there. Curiously, many of them are actually what we think of as contractile protein mutations, but if something's going to contract, it has to be anchored, and the mutations occur where the anchoring is. So this is typically best shown with actin mutations. And then there's other mutations, that's fine. So this is, sorry. Go back to. Thank you. Sorry, finger malfunction here. So this is the list of the genes that cause dilated cardiomyopathy: cytoskeletal genes, sarcomeric genes, Z-disc. This is my own classification, so it's a bit rough and ready. But very importantly, these are all cytoskeletal structural elements. So that's like the RSJs, the beams, the supports of the cell. So there's a weakness in that cell, and when exposed to the trigger, it will come apart, release what shouldn't be released into the immune system, develop an inflammatory response, which causes disease. But look at these genes, which are associated with dilated cardiomyopathy. Desmosomal, 10 to 20%. Lamin AC, again, 10 to 20%. And SCN5A have been implicated. These are all arrhythmic genes, or arrhythmogenic genes. Some of these genes, they have different inheritance patterns: dominant, X-linked, matrilinear, and autosomal recessive, clearly relevant. In the assessment of patient with dilated cardiomyopathy, important then to look at the family background, looking for a first-degree relative with a pacemaker at a young age, or a sudden death at a young age, or some of the more rare associated phenotypes. But these are the key ones. A cousin who's got atrial fibrillation age 28, or someone who died suddenly walking to work, not in extremis in heart failure. Other things that we should do, clearly very obvious in terms of skeletal myopathy and evidence of involvement. This is a nice summary, I think, because we think of dilated cardiomyopathy as, and define it in this way as cardiologists, and we think of it as heart failure. Someone with fatigue, exercise limitation, breathlessness, and that's when you say, oh, my cousin's got dilated cardiomyopathy, that's what you think of. And these are the genes. And in the current vernacular, understanding, knowing which of these genes it is doesn't really influence our clinical management. But that's not true of this. And when in the family history there's an unexplained sudden death of someone who was not in advanced heart failure, or with a sustained arrhythmia, or with a pacemaker at a young age, or young atrial fibrillation at a young age, these are the genes. And knowledge of which gene that is matters, because some of these genes will actually mandate a defibrillator almost all by themselves. And certainly the knowledge of the gene here will influence your management of this family. These are the recommendations of Heart Rhythm, the guidelines from 2011. They're very conservative, probably correct in the era, and probably still correct. If you've got evidence of familial disease with conduction disease or arrhythmia, you need to screen for lamin, SCN5A. Actually, you should also add in desmosomals and the other arrhythmogenic disease-causing genes. Maybe you can be or may be useful with familial dilated cardiomyopathy in these individuals, and if you find something, you should be testing the family. There's no mention here of when you don't have a family history of arrhythmogenic genes, and the guidelines were not to do it. What am I talking about? Well, here is the example of what I'm talking about. This is your sort of standard diagram of the genes which cause arrhythmogenic right ventricular cardiomyopathy. This is the gap junction between a cell on this side and a cell on that side. These are the desmosomal proteins, which are effectively, they're like anchors for the mechanical junction which keeps two cells together. And it's the integrity of that mechanical junction which enables normal electrical transmission. And if this mechanical integrity is altered, then the electrical transmission can be abnormal. Abnormal in our context such that the ECG will have variable T waves, like long QT. Only here you get T wave morphological changes. And they can be variable, they can come and go. Or you can have a primary arrhythmia, and at autopsy the pathologist will tell you, oh, there was some inflammatory cells, maybe it was myocarditis, but there was no fatty fibro replacement. In other words, it didn't look to the pathologist like ARVC. That's the early stage of this condition, and these are the genes. What am I talking about? Well, that's the classic. Here's a family which I think will make the point to you. This, if you had to label this, you would call it an arrhythmogenic dilated cardiomyopathy. This individual, 18 years old, dies suddenly. The heart is seen by Michael Davis, who's a particularly high-quality pathologist, unfortunately has passed on. This is 1998, roughly. And he says, the left ventricular posterior wall has fibrofatty replacement, typical of arrhythmogenic right ventricular cardiomyopathy, but the right ventricle is actually entirely normal. Is this some form of arrhythmogenic left ventricular, right ventricular cardiomyopathy? And until the final sentence of the report was, until we find the genes for this condition, we will not have the answer to this question. We found in this family a desmoplakin mutation. I'm going to show you information on his 63-year-old aunt. We found this mutation, which was found in 11 affected 11 family members. This is her electrocardiogram, and on sort of British membership examination, last choice if you had, is this most likely to be aortic valve disease, dilated cardiomyopathy, hypertrophic cardiomyopathy, or ARVC? It's least likely to be ARVC. This is a left ventricular ECG with T-wave inversion, 2,3 AVF, and particularly V3 to V6, a very atypical for right ventricular cardiomyopathy. Here's the MRI, and volumes are normal. This, what is a wall motion abnormality, is actually moderator band insertion, and this is probably the commonest cause for misdiagnosis of ARVC. But basically this MRI is normal in terms of structure and function, but with late enhancement, at all levels you see mid-myocardial late enhancement of all levels. In this, what looked like normal heart, normal on echo, normal ejection fraction, and given that ECG. And the ECG and this lady's arrhythmia had a morphology consistent with an origin in that part of the free wall. This is the family. It's a bit of an ugly slide, but apologies. But these are the 11 individuals who carry the gene, their ages. basically they're fractional shortening. Most of them had completely normal ejection fractions. Most of them had abnormal electrocardiograms as shown with a left ventricular ECG. And almost all of them they all had left ventricular arrhythmia, and some had left and right ventricular arrhythmia. But you would have classified this as an arrhythmogenic left ventricular cardiomyopathy, but caused by one of the disease genes that causes right ventricular cardiomyopathy. And if you go into a DCM population, that's exactly what you find. 10 to 20% have a desmosomal variant. Where's the clue? The clue is actually in the family history. It's the pacemaker at a young age, it's the sudden death. And some of these family members presented with heart failure, so some of them, when we tracked them down, some were heart failure patients, some were ARVC patients in different people's clinics. And that's what's in our clinics collectively. So the message is actually a good family history is a poor man's gene test. And the family history is pretty simple in the heart failure context. It's anybody in the family with heart disease at a young age that's unexplained, pacemaker, sudden death. And then the fancy things, the other, skeletal muscle, sensory neural deafness, but those are much more fine print. Somebody who dies suddenly walking to work, that is very unlikely to be DCM in the conventional cytoskeletal disease gene. It's one of the arrhythmogenic genes, which means that other family members are at risk. Having preached for the family history and given the context of what we're trying to do here, I'm going to move on to where we are, the modern era. And I would propose that we're somewhere in between 1900 and 1920 with genetics. So if you, 1880, wanted to go into town and go to the shop and buy flour and sugar, you would load the buckboard up, get the family, and go in, and you knew you would get there, it would be safe and reliable. If in 1900 you were one of the affluent enough to have one of these newfangled automobiles, you weren't sure if it would start, and if it would get stuck in the mud or overheat. But there was no question, and it wasn't as reliable as the horse and buggy, but there was no question what the future was. And it was like the early computer versus the typewriter. Similarly disruptive technology. It's not really until we got to the automated assembly line with the same car coming off the assembly line, a gold standard, Henry Ford and the Model T Ford, that we actually began to have a process. And we're somewhere between there and here in that we have sequencing. So the sequence analyzers can now sequence not just 300 base pairs, but 1 billion base pairs. Our ability to interpret that data is big computers, bioinformatics. That's available to us. That will come, and it'll come much quicker than this 20 years, but that's roughly where we are. But we're certainly not quite here in terms of technology we take for granted. I present this slightly against the message of what I'm trying to talk about in family history, but in the context of my role here, where I feel we should be introducing inherited heart disease and genetic testing. And the other message to that is this is, again, in part recognition for the people I've worked with the last 20 years, and some 30 years. It takes a team. It's not one man in a clinic or anybody in a clinic. It's a team, and you're dependent on the geneticists, the genetic nurses, and your different expertises, particularly arrhythmic and imaging, and support from patients' associations. We're not great at communicating a lot of the issues that come up, and we don't, within our cardiological practice, we don't, even when we incorporate the geneticists, we don't adequately deal with patients' angers, fears. If you can imagine losing a child age 7 or 8, what that would do to you. We don't deal with that as cardiologists. So you need a team, and that's what we will hopefully get in place here. Thank you.
Thank you, sir. Thank you, Professor McKenna, for this nice, informative, extremely nice talk. And any questions?
So I couldn't agree with you more. We had a lot of fun in a sort of perverse way, and what we actually did was we did pathology on the explant diagnosis of all of our consecutive transplant and compared it to the diagnosis that was on the chart when they went in, and the single disease that they underdiagnosed was ARVC because we were seeing left ventricular variants.
Yeah.
And as a result, and some of them were formed first, so then we started, because there was no family history, And then we see this, and then we started screening, and unfortunately, as you've outlined, we ended up really looking under rocks and finding many family members gene positive or otherwise, which is obviously to the good, I think, in the long run. But you know, if you don't look, you won't find it.
Yeah, and it's very, I mean, with some sympathy with transplant centers, which are well represented in the front row here. It's, you know, the last thing a patient who needs a transplant wants to hear that the rest of the family are involved. So we haven't, collectively as a community, we haven't dealt with it. It's a hard one to deal with, but it's very relevant. Thank you. Sorry.
Thanks very much. It was a fantastic talk. It's like someone opened up a whole new stream of thinking, you know, in respect of heart failure and so forth. Thanks for that. One of the things I thought about, you know, when you talked about the fibrofatty infiltration of the posterior left ventricular wall, it kind of coincides with what we try to do, is try to get people to think of regional strain in the echo. And I understand the two-dimensional characteristics were normal, and LG on MRI is extremely helpful, if not diagnostic. But the regional strain in that fibrofatty segment, you know, the strain technically, if you get the right points of interest, it can be 0 or positive, because it's either expanding or it's not contracting. So I think this is just another argument why ejection fraction, equating ejection fraction with an echo, or saying, because I can tell you 99% of the time someone comes to the echo lab to ask what the echo showed, all they care about is ejection fraction, and there's so much more. So do you have any thoughts on that type of thinking?
Yeah, we've, yes, I mean, there must be subtle abnormalities that you can pick up with the more sensitive, non-invasive, and particularly echo, which is much simpler when you're studying a family than doing MRI on a large extended family. And we've looked, actually we're looking, I don't know the answer, but we have somebody who is linked with our MRI program and has gone in, and we've got strain on several hundred ARVCs, which is being looked at. We've also looked at our hypertrophs as in the gene positive, phenotype negative. It's the same argument. And they must be, I mean, I'd strongly suspect, I'm more experienced with the hypertrophic in this context, they will be abnormal, we know that actually. But the ARVCs, I don't know. The other thing that's worth pointing out, though we come from imaging biases, the electrocardiogram is still a pretty good test. and you know, a lot of the NAGWA papers related to early diastolic dysfunction in gene positive, phenotype negative hypertrophs, they don't tell you what the ECG showed.
Fantastic talk as usual. Talking about transplantation, it has its value. For example, the biobank in Hatfield with 3,000 specimens from transplant patients who have been phenotyped has been yielding new results, and probably you've seen that there, particularly in combination with more specimens from Boston, looking at Titan mutations. And the first study, which was published in New England Journal of Medicine, showed that Titan mutations, if you add them to the familial cases, we can explain 70% have genetic, but more recently in the current issue of Science Translational Research, the same database, again, looking at RNA and DNA related to Titan mutation, for the first time, there is a relationship to clinical disease. So what you have been campaigning for is now happening, as it's coming to the clinic. And genetics is not in the periphery, and it's not so primitive as you're underestimating yourself and all the work, because it's really becoming center stage. It is coming to the clinic.
At a frontier of understanding disease, I think it's there. I think it is delivering. At a clinical level, if we want to order up a gene test, we still, when we get a full blood count or an SMA, we know what that means. we, as a community, we don't, it's very hard to interpret, and the systems we have, whether it's corporate companies or universities, we don't have a gold standard. We're getting better, and we'll get there. and what we're missing is available. It's big computers and bioinformatics. So it's it'll be there. Yeah.
Thank you so much.
Thank you.